Hi, this is the in-service for Hypokinetic Dysarthria by Casey Hoster and Kira Rogerson. Let's begin with defining what hypokinetic dysarthria is. Hypokinetic dysarthria is a perceptually distinct motor speech disorder associated with the basal ganglia control circuit pathology. The underlying neural mechanisms of hypokinetic dysarthria are rigidity and reduced range of motion. The cause of hypokinetic dysarthria is most commonly due to damage to the basal ganglia, which controls movement, which includes motor functions required for speech. Common etiologies are Parkinson's disease, traumatic brain injury, and stroke. Parkinson's disease is characterized by the loss of dopamine-producing cells. Traumatic brain injury, or TBI, is when there is damage to the basal ganglia, and CVA or stroke is when it is affected to the basal ganglia.
Hypokinetic dysarthria, often associated with Parkinson's disease and other basal ganglia dysfunctions, is characterized by a range of deviant speech features resulting from motor speech impairments. Some hallmark features are listed above. The most common include reduced loudness, monopitch, monoloudness, imprecise articulation, short rushes of speech, and variable speech rate. The basal ganglia is crucial to initiation and intensity of voluntary movements, but it also inhibits unwanted movement. It allows us to learn new motor skills and generate habits based on practice and repetition. The basal ganglia influences our ability to make decisions and plan for the future by evaluating rewards or penalties for future actions, helping us to prioritize goals and block actions that go against our plans. The structural components of the basal ganglia include the striatum, which produces GABA. GABA inhibits unwanted actions. The lentiform nucleus controls, refines, and coordinates voluntary movements. The substantia nigra produces dopamine, which is released by gratifying experience. Dopamine is linked to the regulation of muscle movement, mood, and memory. The subthalamic nuclei is a group of neurons and is considered a processing center for a variety of motor control, sensory process, and automatic movements. Our case study was based on a 51-year-old male. Over 10 days, he experienced multiple myocardial infarctions, also known as heart attacks. This was 3 years ago. At the time of this event, he reported difficulty with speech and problems with his gait.
The physical aspects that we were able to receive from the assessment results included a lack of facial expression, loss of movement associated with facial expression, generalized bradykinesia, generalized rigidity, being more prominent on the left side, reduced range of motion in the jaw, lips, and tongue, and mild left tongue weakness. The assessment results that we got for speech include imprecise articulation, accelerated rate within utterances, monopitch and monoloud, breathy, harsh, strained voice, numerous syllable or phoneme repetitions, fairly frequent word or phrase repetitions that increased with accelerated rate. The repetitions were both voluntary and involuntary. The patient was highly intelligible at a high rate, and AMRs were imprecise and blurred. And the self-report, or what the patient told us during the assessment, included inability to talk in long sentences, having to repeat himself often, bad volume, and easily fatigued and short of breath. Based on our findings, we concluded that he has hypokinetic dysarthria and palilalia. According to the neurologist, there were infarcts on the pitumen and external capsule. He has extrapyramidal disease, diffuse cerebral ischemia secondary to an episode of hypotension. Findings were symmetrical all through, although a unilateral lesion was found on neuroimaging, and the bilateral involvement of the basal ganglia. Our recommendations for our patient is to continue speech therapy services to focus on the positive impact on respiration when his rate of speech decreases, as well as include a backup AAC device to use as the disorder progresses. Our patient was upset because he thought speech therapy was a cure-all, and it ultimately is not, but it can help him, and so we want to continue using therapy to increase intelligibility but not restore what has been lost. After we recommended this, he did seem more willing to do speech and okay with his recommendations. Based on the recommendations, assessment results, and findings, the treatment approach that we recommend is the Lee Silverman voice treatment. It is to help him with his loudness and strengthen his vocal quality to improve intelligibility. It requires intensive therapy for 4 weeks, 4 times a day, and the individual is also encouraged to hear their speech and identify loudness deficits. This addresses many of his deficits, and this approach has strong evidence in improving communicative effectiveness. So we invite you to watch this video on LSVT to see how it works and how to perform the treatment. Resonant voice therapy has also been shown to work with patients who have this type of dysarthria. Resonance voice therapy treatment has been shown to improve vocal strain and fatigue. This technique helps patients learn kinetistics paired with auditory awareness. It also emphasizes the importance of throat posture, and this technique has also been shown to improve voice quality. Advantages of LSVT include that it targets loudness, which in turn improves clarity. It uses repetition and consistency, which targets neuroplasticity. With improved neuroplasticity, a longer lasting effect is achieved. And although not directly targeted, patients have reported that the intonation and facial gestures have also improved while using LSVT, and it is standardized and has been proven effective, which is backed by clinical evidence. However, there are disadvantages. These include the program is very time consuming in the first 4 weeks. There is a lot of fatigue due to the amount of practice that is required. Limiting the target to loudness, which may not address all of the patient's needs. Speaking loudly may appear to be unnatural to the client and the listener, and without regular practice after the initial 4 weeks, skills that have been acquired are easily lost.
RVT enhances vocal efficiency by optimizing sound production with minimal effort. This reduces strain on the vocal folds. It is shown to improve voice quality, projection, and clarity. Additionally, this technique supports long-term vocal health by promoting relaxed and balanced voice use. However, RVT can be challenging for individuals who struggle with self-awareness or have difficulty feeling subtle vocal vibrations. This will potentially slow progress. It requires consistent practice and guidance, which may be time-consuming and demand access to a skilled clinician. The client presents with symptoms consistent with a progressive neurological degenerative condition, such as Parkinson's disease. Clinical findings reveal hallmark speech deviations typical of this population, such as slow rate, imprecise articulation, accelerated rate within utterances, irregular AMRs, and vocal harshness. LSVT is recommended due to its effectiveness in targeting loudness and respiratory support deficits, as well as its potential to deliver quicker results, which may improve the client's motivation after previous therapy dissatisfaction. Additionally, a backup AAC device is advised to ensure functional communication as the condition progresses. The 3 goals we have chosen focus on increasing loudness, intelligibility, and MLU. This will be done within a 4-week time span, as laid out by the LSVT approach. The cueing hierarchy for goal number 1 begins with the direct verbal cue, such as remember to think loud. Next, indirect verbal cue. Do you think that was loud enough? Gestural cue, hand to the ear or a thumbs up. And then to independence, where the client is able to self-monitor and correct. For goal number 2, we begin with direct model cue. And then we move to a direct verbal cue. Slow down. Indirect verbal cue. Make each word clear, and independence. For goal number 3, we began with partial modeling cue. Can you tell me when? Next, a sentence expansion cue. Tell me more about. Gestural cue, hand to the ear or a thumbs up, and then to independence. The 3 compensatory strategies that we chose were rate control, which is consciously slowing down speech, reducing background noise, because quieter settings allow both the speaker and the listener to communicate more effectively, and adjusting posture, sitting upright and maintaining proper chin and neck placement.